I want to start with a picture of a vision that represents a vision of healthcare empowered by technologies and AI technologies. In the last decades, this vision, this paradigm has been empowered by a data-driven vision, a data-driven paradigm. Over the last decades, we have seen this amazing scalability of the data that at the same time has empowered capabilities of methods, technologies. However, I think that there is one actor that is not receiving enough attention here, and that's the metric. Typically, metrics would be a measurement, a value that we use to then benchmark systems, the so-called SOTA, state of the art. And our domain is dominated very strongly by this vision of performance. I want to now show you the circles of influence of metrics to give you an impression of the importance of metrics beyond performance. Starting from science and knowledge, we know that metrics shape what becomes an accepted truth. Going into careers and education, metrics can unlock a faculty position, that new job. Metrics are there to evaluate the skills. In industry and commercial, we know that metrics can define product positioning, market behavior, and so on. In clinics and healthcare, we are certain that metrics can define clinical adoption. Regulatory is clear that metrics define what's approved and what's not approved. Finally, even in society, where metrics can indirectly govern public trust and access, equity of access. So, in a way, dear colleagues, metrics are not just measurements. They are decision engines. And therefore, I think the metrics part is an actor that should receive more attention. And I want to make my case summarizing our journey of 15 plus years in developing an automated brain tumor segmentation system. In the last 4 years, we've been able to translate this as an FDA system that you see here on top. That is now in several clinics in the US. And at the bottom, this is the new journey. It's the second FDA-approved system that we have released a year ago for brain metastasis patients. Now, this journey has been very exciting, very challenging, but also very humbling. For the sheer number of cases that the system now has seen, has given us so much perspective and lessons learned that I like to summarize in something I want to call the 3 R's of clinical AI, for robustness, reliability, and resilience. Robustness is all about predictions that can remain accurate despite imperfect or shifted data. So let's go back to our classical picture of performance metric. An average performance is king many times. However, in the clinics, robustness is very important, for we want a system that performs. It might even have a superhuman performance, but definitely we don't want a system that from time to time just fails miserably. We need to compare robustness with integrated variability, for that defines that region of operability of an AI system where every single result of that AI system should fall within, not just the average performance. In our community of BRATs, brain tumor segmentation, over the years, we have seen these improvements brought by scalability and capability of systems and technologies. When we zoom into the top performance model systems, we see something that's a very classical snapshot of the situation we see across different systems. An illusion of performance stagnation, where we start fighting for little deltas, where a p-value becomes so important for that paper to be submitted, right, to convince reviewer number 2. However, when we look at the whole picture, is where we start seeing the reality, where this red region here, this is the failure mode that typically we don't want to talk about, but this is the region that we should embrace. This is the window opportunity for us to understand. So many times, we just look at average performance and we say it's very similar to the human, but the reality is different. We need to embrace that window opportunity. We also need to understand better their interplay between robustness of AI systems and models elements. What you see here is an illustration of one AI backbone called the UNIT, that is the workhorse for segmentation systems in biomedical engineering, and their variants. One system might have one of these skip connections that are very important for these backbones, and all the way to a variant of that unit architecture that doesn't have any of that. When we look at pure performance of these systems across tasks, we see that, yeah, those variants outperform the one where there are no skip connections. But when we start looking at robustness of the systems, we need to look at the whole scale. For when we add perturbations, we start seeing that that very nice performance starts plummeting. For the bottom line in clinical AI is that if robustness is not ensured, an average performance becomes irrelevant. Let's move now to the second R of reliability. This is all about reproducible outputs clinicians can trust daily. So this is as an example of systems that can perform a classification between a low-grade and a high-grade glioma. And back in the days when we started looking at explainable AI methodologies, we would look situations like this one where the system is suspiciously looking at areas that have nothing to do with the biology of a low-grade or high-grade glioma. When fixing for that, after that realization, we will improve the system performance, but beyond that, its reliability. In the last years, we've been working on a paradigm called human-AI alignment, and looking beyond performance again, other dimensions such as fairness. And what you see here is a snapshot of a system that is not aligned to the human and has this pairing of fairness gap and performance. When we start adding alignment to the model, we start seeing a pattern where the model benefits in both dimensions. But here comes the catch. That balance, that trend breaks. And this balance is broken. The guidance between and pattern discovery, the guidance of the human, making sure that system is reliable, and pattern discovery, that's the data-driven approach we follow these days. And this is reminiscent of the AlphaGo moment, the so-called Move 78, where the system learned something the human did not know. So understanding that balance between pattern discovery that can be fundamental. Today's systems, we use them to solve problems, but we should start using them to learn from the data. And that guidance, because patient safety is ultimately the most important thing. And the last R of resilience. It's all about recovery and adaptation after operational disruptions. You might have a system that sees a new scanner or protocol, sees an edge case, a distributional shift. That system, once deployed, needs to adapt, needs to recover, but in the clinics, needs to adapt very fast. Now, luckily in our community, we have technologies for resilience. As you can see here, many different approaches. The challenge now is to have a mindset change where beyond performance, once again, we start looking at what is the resilience of the systems we are developing. So we have the 3 R's of clinical AI: robustness, reliability, and resilience. In our technical communities of AI, we have many tasks, and you can maybe see many of these tasks. You've been working on that, and for which we also have many metrics that we use to quantify the goodness of an AI system on those tasks. The good news is that we can already map robustness, reliability, and resilience. So once again, we are somehow already equipped with the technology, but it's a mindset change that we need to adopt. Ultimately, these metrics should correlate with clinical goals. We should not stop at the technical metric and say, my paper has a better metric than the previous one. We should look into the correlations with clinical goals. To give you an example, we started looking at that correlation several years ago for treatment planning and contouring metrics, to realize that the correlations we found were actually pretty weak, showing us that those metrics we really we really like, we use for training and evaluation of AI systems, do have blind spots. So next to evaluation of AI systems, we need to ask ourselves the question, can we train now systems to be clinically relevant? In the case of radiation oncology, we've been now exploring systems that are trained with clinical objectives. As you can see here, not only at geometrical compliance that's typically done in contouring, but also at dosimetric compliance. And there are so many other aspects that are very important as end goals, with promising results for brain, but also recently also for head and neck. So let me summarize now. I hope after this short talk, I was able to convince you to look into the 3 R's of clinical AI. An AI system that is robust, that can withstand perturbations, an AI system that's reliable, that can be trusted daily, and a system that's resilient. It can recover, and it can recover fast. I hope I was able to convince you that understanding failure mode is not an afterthought. It is a design principle. And even beyond pure performance metrics, I hope I was able to convince you that it's important to evaluate and even train systems to be 3R compatible and even clinically relevant. With this, I finish my talk. I want to thank all collaborators and you for being part of this great AI in cancer community. Thank you very much.